Hi. Good afternoon, everyone. How are you all? Okay, enjoying DVT? Okay. So after the first session by Tiwari sir, it was a great session. I was also listening to him. Okay, so let's quickly we'll revise this part. In this, we'll first do hepatobiliary pancreatic system, and then we'll do the revision of the urology. Okay, so you ready? Okay, so let's start hepatobiliary pancreatic system first, and then we'll do the other parts. Okay, so the anatomy of liver. Okay, anatomy of liver, I hope you all remember. The liver is divided into 8 segments by coinoids. Okay, so these segments are divided based on what? Divided based on the division of the portal vein and the hepatic vein. Okay, so this is the portal vein, which is the, you can say, the horizontal line, and these are the hepatic veins, which are the vertical lines. So based on these divisions, the liver is divided into 8 segments. Okay, so segment 2, 3, and 4. This is the left liver, and 5, 6, 7, 8 is the right liver. Okay, every segment has its own portal triad, means every segment has its own branch of hepatic artery, portal vein, and bile duct. Okay, so you can see segment 2, 3, 4 is the left liver, and 5, 6, 7, 8 is the right liver. Okay, so based on this, now you tell me, this is a very important question about the Brisbane terminology of the liver resection. Okay, Brisbane terminology, left hepatectomy, what are the segments you will remove? 2, 3, and 4. Right anterior sectionectomy, what are the segments you will remove? Anterior, 5 and 8. Posterior, 6 and 7. Left lateral sectionectomy, 2 and 3. Medial, 4. Trisectionectomy. Now this is the most important. Trisectionectomy, 5, 6, 7, 8 and 4. Left, 2, 3, 4, 5 and 8. Okay, so this is the last 2. These are very important terminologies. Next thing, in the liver carcinoma, what is the most important risk factor or the most common risk factor? Most common risk factor is hepatitis B. Hepatitis B, C, alcohol, these are the common risk factors. Clinical features, mostly the triad which you will see is the mass in the right hypochondrium, pain, and the later stages you can see the jaundice, weight loss, etc. Now the important question is, what is the most common paraneoplastic syndrome? Most common paraneoplastic associated with hepatocellular carcinoma? Hypoglycemia. Okay, hypoglycemia. And what is the most common paraneoplastic with RCC? Raised ESR. Okay, so what is the investigation of choice for hepatocellular carcinoma? Investigation of choice is triple phase CT. Okay, triple phase CCT. And what is the characteristic feature in this triple phase CCT? There is enhancement in the arterial phase. Okay, enhancement in the arterial phase, because although liver is getting its main blood supply from the portal vein, but the hepatocellular carcinoma is exclusively supplied by the hepatic artery. Okay, so triple phase CT, suppose this is not in the option, then MRI is the best answer after this. Tumor marker is mainly clinically used tumor marker is alpha-fetoprotein. Also there is PIVCA2 that can also be used as a tumor marker, but practically speaking, alpha-fetoprotein is the main tumor marker. Okay, so triple phase CT is the investigation of choice. Now there are certain stagings like Okuda stage. Okay, so exactly like the point wise is not important, but yes, you need to remember what are the parameters we see. Okay, tumor size, if it is involving less than 50% of the liver, it is 0, more than 50% is 1, no ascites 0, if there is ascites 1 point, albumin more than 3 gram and less than 3 gram, and bilirubin less than 3 milligram and more than 3 milligram. So Okuda stage 1 is when you have 0 points. Stage 2 is if you have 1 or 2 points. And 3 is if you have 3 or 4 points. Higher the stage, poorer is the prognosis. Okay, the high stage prognosis is poor in that. Okay. Next staging is CLIP, that is Cancer Liver Italian Program. Child 2 class, we all know child 2 has A, B and C. So child 2A, the score is 0, B is 1, C is 2. Tumor morphology, if it is uninodular, it is 0. If it is uninodular but involving less than 50% of the liver, 1. And if it is multinodular, it is 2. AFP level less than 400 and more than 400. Okay, less than 400 is 0, more than 400 is 1. Portal vein thrombosis, no, 0, yes, 1. Okay, so in this case also, the higher the score, poorer is the prognosis. The main thing which you need to remember is that we see child 2 score, tumor morphology and alpha fetoprotein level along with portal vein thrombosis. Okay, so these are the, we can say the two important stagings. Now child 2 classification is not only for the hepatocellular carcinoma, it is for any liver disease. Okay, for any hepatic disease, we want to know the hepatic reserve in the patient. For that we see child 2 classification, and this is important. You need to remember this classification because you might have been, this has been asked in the prior exams to calculate this. Okay, so bilirubin, less than 2, 2 to 3, more than 3. Albumin more than 3.5, 2.8 to 3.5, less than 2.8. Ascites, no ascites, controlled ascites, uncontrolled ascites. Prothrombin time, basically we see INR less than 1.7, 1.7 to 2.3 and more than 2.3. Encephalopathy, no. Controlled and uncontrolled. Okay, so the range can be from 5 to 15. If there are 5 to 6 points, okay, 5 to 6 points, it is class A. 7 to 9 points, it is class B, and 10 to 15 is class C. So patients who are having child 2 score A, okay, these are the patients who have good hepatic reserve. So in these cases, you can go for major hepatic resections. Okay, major hepatic resections can be done in these cases. In class B, 7 to 9, you can do minor hepatic surgeries or minor resections. But in class C, the hepatic reserve is so poor that you cannot do any major or minor hepatic resection. For these patients, the only, you can say the chance of cure is you need to change the liver, that is hepatic transplant. Okay, next about the treatment, you need to know that BCLC is Barcelona Cancer Liver Clinic. You don't need to know this exact algorithm. Okay, I don't want you to remember this. I want you to remember that if you get a question of hepatocellular carcinoma in the exam, then which answer you are going to mark. Okay, because for the treatment, for the cure, there are 3 options. Basic, the most important is liver resection. Okay, so if there is a single HCC in a non-cirrhotic liver, single HCC, the first line treatment is resection. And if it is a cirrhotic liver, the first line treatment is transplant. Okay, non-cirrhotic liver resection is the first line treatment, cirrhotic liver transplant is the first line treatment. And many times the patients are not the candidate for either resection or transplant. Okay, so then you'll go for local ablative therapies. Local ablative treatment options like radiofrequency ablation, percutaneous ethanol injection. So this is for those patients who are not a candidate for resection or transplant. Okay, so now tell me, what is the criteria for liver transplant in hepatocellular carcinoma? This is very important. The name of the criteria is Milan's criteria. Milan's criteria. So as per the Milan's criteria, if it is a single HCC, which is less than 5 centimeter, in case of multiple tumors, if there are multiple tumors up to 3, So if there are more than 3 tumors, you cannot do, and none of the tumors should be more than 3 centimeter, and no major vascular or extrahepatic spread. Extrahepatic spread. Although these days people, they believe that transplant and resection, among these two, transplant is a better option. But you have to follow this thing, that transplant is reserved for, because transplant is something which is not readily available, or you cannot, simply do the transplant. You need to do, you need to find a donor, and there are lots of, matching issues and the legal issues. So that's why resection is still the first line treatment in single HCC non-cirrhotic liver. Okay, so this is Milan's criteria. Now we'll see resection of liver based on future liver remnant. So what is the minimum FLR? FLR is future liver remnant in a non-cirrhotic liver. In a non-cirrhotic liver, what is the minimum FLR? Although practically people, they believe 25 to 30%, but if you have an option of 20%, then that is a better answer. Okay, you can say 20 to 25% in a non-cirrhotic liver, and if it is a cirrhotic liver, then it is 40%. Okay, so 40% for cirrhotic liver and 20% for non-cirrhotic liver is the minimum FLR. So many times when you are planning a resection in a hepatocellular carcinoma, usually hepatocellular carcinomas are large in size. So before planning the resection, you get a CT volumetry done. Okay, so CT volumetry will tell you before the resection that what is going to be the FLR. So in that case, if the FLR is supposed less than 20% or less than 40% in cirrhotic, then to increase the FLR, these two are the options. Okay, portal vein embolization and associating liver partition and portal vein ligation for staged hepatectomy. These are the two important things to increase the FLR. Now, ALPPS is an important question, and the most important thing which you should remember about the ALPPS is the full form. Okay, this question has been asked in the INI-CT exam. You need to remember the full form. Okay, so in ALPPS, in stage 1, what we do is we just ligate the portal vein and transect the liver. Transect the liver, but we don't remove anything. The liver is still supplied by the hepatic artery, and the portal and the, you can say, the bile duct is still coming. So in a week, you will see that you get the sufficient FLR, and then after a week, you will remove this remaining part of the liver. Okay, you can complete your hepatectomy. 80% of the thing you have already done, so you just have to take out that liver. If you do a portal vein embolization, you get the sufficient FLR in 3 to 4 weeks. In ALPPS, you get that in 1 week. Okay, so that is the main advantage. In ALPPS, you get the sufficient FLR in less time as compared to the portal vein embolization. Okay, so this is also important question about the comparison between hepatocellular carcinoma and a variant of hepatocellular carcinoma, that is fibrolamellar carcinoma. Hepatocellular carcinoma is more common in males 4 to 8 times, but this is incidence is same. Okay, age hepatocellular carcinoma usually you see in like 50 to 60 year age group, fibrolamellar 20 to 30, younger patients. Tumor nature, it is more aggressive, and fibrolamellar is well circumscribed. Well circumscribed. Resectability is better in fibrolamellar. This hepatocellular classical is associated with cirrhosis. This is not associated. Alpha fetoprotein will be raised in fibrolamellar. It will be normal in it will be raised in hepatocellular, and it is normal in fibrolamellar. Association with hepatitis B seen in classical, it is not seen in fibrolamellar. Prognosis is not very good in hepatocellular, but it is quite good in fibrolamellar type of hepatocellular carcinoma. Okay, so this is important question, the difference between hepatocellular and fibrolamellar. And in fibrolamellar, just one more thing you remember, on the CT, you will get a central scar. Central scar on CT in fibrolamellar variety of hepatocellular carcinoma. Okay, portal hypertension. What is the normal portal pressure? 5 to 10 millimeter. Portal hypertension is more than 10, but usually the complications like variceal bleed, you will see in more than 12 millimeter. So more than 12 millimeter, you will see complications. So if the patient is having acute variceal bleed, then what is the drug of choice? Octreotide. Octreotide. In few books it is written terlipressin, but octreotide is a drug of choice. And for the prophylaxis, beta blockers. Okay, beta blockers, propranolol. And when the patient is having acute variceal bleed, what is the best way to control it is endoscopic variceal ligation. Okay, endoscopic variceal ligation is the best method to control the bleed. In those cases where it is not available or it is not able to control, you can use a balloon tamponade, and that tube is known as Sengstaken Blackmore tube. Sengstaken Blackmore tube. TIPS these days is a very commonly used procedure in which you will come via the jugular vein, come inside the liver and do a shunt between a branch of the portal vein and a branch of the hepatic vein. So that is transjugular intrahepatic portosystemic shunt. And there are selective shunts. You can say the surgical shunts, non-selective and selective. I want you to remember just the example of the selective shunt. What is the name? Distal splenorenal shunt. Distal splenorenal shunt is a selective shunt. The advantage of selective shunt is when you do this selective shunt, a part of the blood is still going to the liver, so the chances of encephalopathy is less in selective shunt. And if all these procedures they fail and the patient is having severe bleeding, then to save the life of the patient, that is the last resort, devascularization procedure. The name is modified Sugiura surgery. Modified Sugiura surgery, in which you will transact all the venous drainage to the proximal stomach and the distal esophagus and do a splenectomy. Okay, so this is how you manage a variceal bleed. Okay, so the next thing, liver infections. Pyogenic liver infection. What is the most common cause? E. coli. Amoebic Entamoeba histolytica. Entamoeba histolytica. Age. This is seen usually in elderly people who are immunocompromised. And amoebic liver abscess is seen in young immunocompetent patients. Clinical features, pain, fever, and jaundice. In amoebic, you will see pain, fever, but jaundice is not very common. You can see hepatomegaly, and there will be some history of diarrhea or some history of, you can say, the lower abdominal pain because of the initial amoebic colitis. Most common LFT abnormality, very important MCQ question. So what is the most common LFT abnormality? Raised alkaline phosphatase in pyogenic and raised PTINR in amoebic liver abscess. Treatment is usually you need to do drainage. Okay, mainly pigtail drainage or the percutaneous, you can do needle aspiration. But for amoebic liver abscess, metronidazole is the drug of choice. In very few cases, you need to do the drainage, like if the abscess is more than 5 centimeters, if it is a left lobe abscess, in case of pregnant females. Okay, so in that case, you need to do drainage. Otherwise, metronidazole is the main treatment, and the dose is 750 milligram 3 times a day for at least 10 to 14 days. Okay, so what kind of abscess you will see in amoebic liver abscess? I mean the color of the abscess. Anchovy sauce. Okay, this is anchovy sauce abscess. And on CT, on ultrasound, you will see a hypoechoic lesion. And on CT, you will see a hypodense with a peripheral rim enhancement. Okay, peripheral rim enhancement you will see on the CT scan in abscess. So this ultrasound and CT finding you will see in both the types of abscess. Okay, so generally looking at the the CT or ultrasound, you cannot differentiate whether it is pyogenic or amoebic. But yes, there are other methods like amoebic serology, which is commonly done to differentiate from the pyogenic. What is the diagnosis in the next case? There is a CT image, there is an ultrasound image. Okay, so what is this? Hydatid. Okay, it is a hydatid disease. What is the drug of choice in hydatid? Albendazole. Albendazole is the drug of choice. So this CT image is very important. In the past 2 years, there are many questions on which they just give a CT image and they ask you about the diagnosis. So this is hydatid disease. Treatment is, you can either do a surgical resection or you can go for a percutaneous aspiration, injection of scolicidal agent, and re-aspiration, that is pair procedure. Now tell me, looking at the image, identify the benign liver lesions. Okay, this is a CT showing a, what is this? Hemangioma. How do you say it is hemangioma? Because there is, initially the contrast comes in the periphery and then it comes in the center. Okay, so initial early peripheral enhancement with centripetal filling. And this is also hemangioma on MRI. On MRI, this will give a very hyper intense lesion in the T2 weighted image, very hyper intense. So this is hemangioma. And another important image of a benign disease where you will see a central scar. What is the diagnosis? FNH. FNH, focal nodular hyperplasia. So you will see a central scar in FNH. Okay, there is no special feature as such for the adenoma. So about the adenoma, what is the most important risk factor? You'll get in the exam. OCPs. What complications can occur? Maximum risk of bleeding, maximum risk of rupture, and also there is risk of malignancy. It can turn into a hepatocellular carcinoma. The hemangiomas and FNH, they generally don't turn into a cancer, but this can turn into a cancer. Okay, and these are the different types. So in these types, beta-catenin mutated has the maximum risk of cancer. HNF alpha, minimum risk of cancer. And inflammatory is the most common type. Okay, so the most common type, maximum risk of malignancy and minimum risk of malignancy. These are the important things about the benign liver tumors. Biliary system. Okay, so one important thing which I want to clear is, see, previously there was some confusion between the hepatocystic triangle and the Callett's triangle. Okay, so this triangle, that is the inferior surface of the liver, common hepatic duct, and the cystic duct. Okay, previously people used to call this as hepatocystic triangle, and the Callett's triangle was the, you can say this cystic artery, common hepatic duct, and cystic duct was Callett's. But now all the books, including Bailey and Love, has cleared this, that the common hepatic duct, inferior surface of liver, and the cystic duct is Callett's triangle. Okay, so you don't have to remember anything other than Callett's triangle. Inferior surface of liver, common hepatic duct, and cystic duct is Callett's. Okay, no confusion should arise in this. All the Blumgart is you can say that is a Bible for hepatobiliary. That also says the same thing. But can you see in this image, you can see the common hepatic artery or the right hepatic artery which is in the Callett's triangle. This is known as caterpillar hump or Moynihan's hump. Moynihan's hump or caterpillar hump. So while doing the cholecystectomy or while doing the surgery in this area, one should be careful because people might think this as a cystic artery and they might ligate this. So remember, this is Moynihan's hump when the common hepatic or the right hepatic artery comes in the Callett's triangle. Choledochal cyst. What is the cause of choledochal cyst? What is the cause? Anomalous pancreatico-biliary ductal union. Okay, so this is the most acceptable theory for the formation of this choledochal cyst, which is dilatation. So anomalous pancreatico-biliary ductal union is when there is a long common channel. When there is a long common channel between the CBD and the pancreatic duct, if this common channel is more than 15 mm, then it is known as anomalous pancreatico-biliary ductal union. A Todonic classification is a classification of choledochal cyst. Just quickly tell me, what is the most common type? Most common type of choledochal cyst. Forget about 1A, 1B, 1C. Most common is type 1. Okay, among 1A, 1B, 1C, 1C is the more common, but you need to remember type 1 is the most common. Okay, in type 5, you can see there is multiple, you can say the dilatation inside the liver, so that is intrahepatic cysts. Type 1 is the most common, type 4A is the second most common, and type 2 is the least common. Type 4A is the second most common, and type 2 is the least common. What is the triad? There is pain, lump, and jaundice. And all these features are intermittent. Okay, intermittent pain, lump, and jaundice. This is what you see in choledochal cyst. Now see, MRCP is the investigation of choice. On ultrasound, you will see just a dilated CBD. Investigation of choice is MRCP. You can see the fusiform dilatation, the saccular dilatation. Okay, type 3 is the dilatation of the intraduodenal part of the CBD. Type 4A, when you will see both the intrahepatic as well as extrahepatic dilatation. Type 5 is Caroli's disease. Okay, it is Caroli's disease. You will see multiple intrahepatic dilatations. Caroli's disease. So for Caroli's disease, the treatment is liver transplant. Okay, liver transplant is the main treatment for Caroli's disease. Okay, so management may just remember for type 1, 2, and 4B. It is excision and Roux and Y hepaticojejunostomy. Type 4A and 5, where the cyst is present in the liver, it is liver transplant. Okay, liver transplant is the treatment. And for type 3, which is intraduodenal, you can go either via the duodenum or through the ERCP and do the cyst excision. I mean endoscopic or transduodenal excision of the cyst. So when you do excision, you do a little bit of sphincteroplasty also, so that it will not cause any narrowing or stenosis in that area. Okay, so this is the Roux and Y hepaticojejunostomy. You can do a loop hepaticojejunostomy also, but this is the preferred treatment, a Roux and Y hepaticojejunostomy. Extrahepatic biliary atresia. Okay, type 1 is when it is involving only the CBD. Type 2 is if it is involving the common hepatic duct also. And type 3 is when it is involving the right and left hepatic duct also. Type 3 is the most common type. Type 3 is the most common type. Clinical features, it is mainly the jaundice which is present at the time of birth, and there are features of obstructive jaundice. And intrahepatic biliary atresia, the only treatment possible for this is liver transplant, and this question has been asked multiple times in the AIMS exam, NICT, that what is the most common reason for liver transplant in the pediatric age group? It is biliary atresia. Okay, the most common cause of liver transplant in children is biliary atresia. The most common cause for liver transplant in adults is hepatitis C. Okay, Hep C is the most common cause in adults. In children, it is liver transplant. In children, it is biliary atresia. So in biliary atresia, when you do the ultrasound, you will see something known as triangle cord sign. On HIDA scan, you will see that the tracer is not coming out of the liver, so that shows that it is type 3 biliary atresia. Otherwise, this black color thing you will see, it will be coming into the through the outside the liver and going to the duodenum, which you cannot see in these cases. Okay, so this is the HIDA scan. The treatment is you can go for Ru and Y hepaticojejunostomy for type 1, Ru and Y hepaticojejunostomy, and for type 2 and 3 extrahepatic, the treatment is portoenterostomy. Portoenterostomy, which is also known as Kasai's procedure. You can call it as portoenterostomy or portojejunostomy, that is the same thing. Okay, intrahepatic we have seen, it is transplant. Okay, so next thing, the cholelithiasis, which is the most common stone, which is the most common type of gallstone. Overall, mixed is the most common. Pigmented is most common in the Asian population, including the India, and cholesterol is more common in the West. In the Western population, cholesterol is more common. Cholesterol stone we say when the main, we can say the cholesterol is forming more than 70% of the stone. More than 70% of the stone is formed by the cholesterol. In pigmented, mainly it is calcium bilirubinate. And in mixed, there is a cholesterol, there is calcium bilirubinate, calcium carbonate, and other calcium salts also. Now see, because pigmented and mixed have some calcium salt, so they may be seen on the X-ray. Okay, they can be seen on the X-ray, but X-ray is not a very good modality to see these things. Cholesterol stones will be radiolucent. Okay, cholesterol stones will be radiolucent, pigmented or mixed may be seen on the X-ray. Investigation of choice for gallstone, ultrasound. And what will you see on the ultrasound? That there is a hyperechoic stone with the posterior acoustic shadow. Okay, posterior acoustic shadow. This is also hyperechoic, but you cannot see any posterior acoustic shadow, so this is a polyp. This is a gallbladder polyp. And in this case, when you see the thickening of the wall, that you will see in acute cholecystitis. Acute cholecystitis. If a patient comes with a gallbladder polyp, incidental finding of gallbladder polyp, which is 7 mm in size, what will you do? 7 mm in size. You will do follow-up. When will you do surgery in polyp? If it is more than 10 mm. More than 10 mm, there is increased risk of cancer. So that's why in more than 10 mm size of the polyp, you will do surgery. Less than 10 mm, you can do follow-up. And people generally say that if the size is more than 20 mm, then consider it as malignant. Okay, more than 20 mm, many people, they consider it as malignant and they go for the radical cholecystectomy. Okay, so acute cholecystitis, investigation of choice is ultrasound. Okay, clinically, you will see pain, guarding, rigidity, tenderness. There can be fever. There will be increased TLC count. So this is how you differentiate acute cholecystitis from a biliary colic. But what is the best investigation? This is a question, exam question. HIDA scan. Okay, so most sensitive or the best or most sensitive investigation is HIDA scan. What is the management? Management of acute cholecystitis, if the patient comes in less than 72 hours from the beginning of the symptom or more than 72 hours from the onset of the symptoms. What is the management? When the patient comes in less than 72 hours, there will not be much adhesions around the gallbladder, so you will go for a laparoscopic cholecystectomy. Okay, but if the patient comes after 72 hours, there will be adhesions and inflammation, so you will do conservative management. Conservative, and later on, after 6 to 8 weeks, you will go for surgery, that is laparoscopic cholecystectomy. Okay, so remember the management depends on how early or how late the patient is presenting to the hospital. Now, laparoscopic cholecystectomy, what is the important thing you need to see or you need to realize in these cases is when you do a laparoscopic cholecystectomy, when you start doing the dissection, So you do the dissection in the Callet's triangle, and before ligating the structures like the cystic artery and the cystic duct, you have to be very, very sure that there are only these two structures present in that area. Okay, because there are chances that maybe some aberrant duct or maybe the CBD is going there and people think it has cystic duct, they ligate the CBD, they cut the CBD. That is something which should never happen in a cholecystectomy, and believe me, daily people are doing these mistakes. Okay, so we see so many patients who come with, they cut the CBD, they ligate the CBD. So this is known as critical view of safety. Okay, exam question, critical view of safety. You have to see just two and only two structures during the laparoscopic cholecystectomy. And the second important thing is you have to stay close to the gallbladder. Okay, stay close to the gallbladder. Don't try to go and see the junction of the cystic duct and CBD. You need to stay close to the gallbladder. This is the area which should not be explored during the laparoscopic cholecystectomy, because if you try to go and see there are high chances you will do some injury. Okay, so critical view of safety, stay close to the gallbladder. These are the two things that will make this surgery very easy and very safe surgery. Classification of bile duct injury. Very, very important classification in the biliary system. Strasberg classification. A is when you see the bile leak from the cystic duct stump. Okay, you can say there is, don't see this thing, just see that if there is bile leak from the cystic duct stump, that is considered as class A. Class B is when there is ligation of the aberrant sectoral duct. Okay, this is the aberrant right sectoral duct, and if you don't see this and you ligate it, it is class B. Class C is when there is bile leak from the aberrant sectoral duct. Okay, so remember in class B there is no bile leak. This was a question in which type of injury you will not see bile leak. In class B there is no bile leak, but in rest of the thing you will see the bile leak. So class C is when there is leak from the aberrant sectoral duct. D is when there is partial injury into the main duct. Main duct means either common hepatic or CBD. And class E is when there is complete transection. When there is complete transection, so this E is divided from E1 to E5 depending on which level this transaction has occurred. So that is given as per the Bismuth classification. We'll see the Bismuth classification. So this E is from E1 to E5, like more than 2 centimeter from hilum, less than 2 centimeter from hilum, at the hilum. Okay, so this is as per the Bismuth classification. Okay, so see, this is Bismuth. Mainly it is for stricture. Bismuth classification. More than 2 centimeter type 1, within 2 centimeter type 2, at the hilum, but remember the right and left hepatic duct confluence is maintained. The confluence of right and left hepatic duct is maintained. In type 4, it is separated. Okay, the right hepatic duct and left hepatic ducts are separate. And type 5 is when the stricture occurs in the aberrant sectoral duct. Aberrant sectoral duct. So this Strasberg and Bismuth consider this as one of the very, very important classification in the hepatobiliary system. Every year there are questions on this Strasberg and Bismuth classification. Now, management of bile duct injury. So management can be divided into if you can identify the injury during surgery or if you identify it in the post-op period. Every year the question is on this. So intraoperatively, suppose you are doing a laparoscopic cholecystectomy and at that time only you find out that there is injury. So what will you do? If the injury is involving less than 50% of the circumference and it is not by cautery. Okay, cautery injuries, that is electrocautery or diathermy, those injuries are always dangerous. Okay, maybe at that time it will look small, but because of the thermal energy, the later on you will come to know that actually the injury was more extensive. Okay, so injury less than 50% and not by cautery, you can do primary repair over a T-tube. Over the T-tube, you will do the primary repair. Okay, but if the injury is more than 50% or it is by cautery, then you have to resect a part. You have to resect that part which is injured. After resection, if this gap is less than 1 centimeter and not near the hilum, then you will do end-to-end anastomosis. You will bring two ends and do end-to-end anastomosis. In this case also, most of the people, they put the T-tube, but not from the site of the repair. You will put the T-tube somewhere down. You can put the T-tube. But if the injury is, or if the gap is more than 1 centimeter, or it is near hilum, then you will do a hepaticojejunostomy. You will do a hepaticojejunostomy. You can close the distal end, and proximal end is anastomosed with the jejunum. Okay, hepaticojejunostomy. So remember what you are supposed to do if you can find the injury at the time of surgery. And every year, see last to last year, and like 2 years back, this question was asked about the bile duct injury. So you should be very, very clear the criteria, the guidelines in the post-op period. Okay, in the post-op period, how does the patient come? Suppose you have done a laparoscopic cholecystectomy, you discharge the patient next day or maybe on the same day. Patient will come to you after 2-3 days with the complaints of pain, with the complaints of fever, with the complaints of jaundice. So at this time, if you explore the patient, the edges are inflamed and you try to take the bite, you try to do the suturing, your suture will not hold. Okay, so what will you do in the post-op period? First, you drain the bile. Okay, drain the bile. You put a drain by the help of ultrasound, or you can do the surgery and put the drain. Get the MRCP done to see where is the injury, how much is the injury, and then go for a delayed repair. Delayed repair after maybe 8 to 12 weeks later, you can go for a hepaticojejunostomy. If you try to do the surgery in the post-op period, like 2 days, 3 days later, your suture will not hold, so you will wait for some time so that the edema settles, so that the inflammation settles, and then you do a delayed repair hepaticojejunostomy. Okay, so remember this is one of the most potential questions from the surgery which you are going to get in your exam. Okay, about the management of bile duct injury, the classification of bile duct injury. What is the diagnosis? Looking at this gross specimen, last year's question. Okay, multiple yellow flakes. This is cholesterosis, which is also known as strawberry gallbladder. Okay, what is the diagnosis in this? Where you can say a comet tail artifact. Comet tail, adenomyomatosis. Adenomyomatosis. Okay. Now see, what has happened in this case? What is this what is this basically condition? What condition is this? Where you will see a stone present in the Hartmann's pouch or in the cystic duct, which is causing compression of the main duct. Okay, this year in the super specialty exam NEET, this question was asked. This is Mersey syndrome. Mersey syndrome. There is a classification of Mersey syndrome. Type 1 is when it is causing only compression. There is no fistula. In type 2, there is a fistula that involves less than 1/3 of the circumference of the common duct. 1/3 to 2/3 is type 3. And if it is more than 2/3 or the entire wall, it is type 4. And type 5 is when there is cholecystoenteric fistula along with this Mersey syndrome. So you can call it as cholecystocholedochal enteric fistula. So these are the types of Mersey syndrome. Okay, so these are the different types of Mersey syndrome. Most of the time treatment you can say subtotal cholecystectomy. Subtotal cholecystectomy, you will leave that part of the gallbladder which is present very close to the CBD. Rest of the gallbladder you can remove along with the stone. Okay, this is a plain X-ray. Tell me the diagnosis. Left side picture, this picture, plain X-ray. What can you see? There is a calcified globular structure in this part. So calcification of the wall of gallbladder, porcelain gallbladder. Okay, and this is the CT of the porcelain gallbladder. You can see a very nice calcification in the gallbladder. Next image. Okay, this is showing a stone This is showing a dilated bowel loops, and if you can see closely, you can see air in the biliary tree. Okay, so this is a triad known as regular triad. Regular triad. What is the diagnosis? Gallstone ileus. Gallstone ileus, where the gallstone, it comes in the intestine and cause the obstruction in the terminal part of the ileum. That is gallstone ileus. Okay, that is gallstone ileus. Suppose the gallstone, they cause obstruction there only, in the duodenum only. And this will lead to gastric outlet obstruction. What is that syndrome is known as? Very important. Important MCQ. Bouveret syndrome. Okay, so gallstone causing gastric outlet obstruction is Bouveret syndrome. Gallstone causing intestinal obstruction is gallstone ileus. The most common site of gallstone ileus is the terminal ileum. The most common site of the fistula between the gallbladder and the intestine is the first part of duodenum. The first part of the duodenum is the most common site where the cholecystoenteric fistula occurs. Okay, so remember Bouveret syndrome is gastric outlet obstruction due to gallstone. So suppose the patient comes with gallstone ileus, what is the treatment or what is the surgery you will do? Whether you will do the treatment of the obstruction and at the same time you will remove the gallbladder, or you will do only the treatment of the obstruction in the initial phase. In the initial phase, you will treat only the obstruction, and in the second stage, maybe during the same admission, a week or 10 days later, you can treat the gallbladder and you can repair the, duodenum. Okay, so initial phase may remember, you will only treat the obstruction part. Don't try to take out the gallbladder and repair the duodenum in the first phase, because when the patient comes in the emergency, they are not that fit enough to go for a long duration surgery. So at that time, you will do the only minimally required thing, so that is relieving the obstruction. Gallbladder carcinoma, the most common risk factor is gallstone. This is the most common risk factor. 90% of the cancers are because of this, and especially if the stone is more than 2.5 centimeters. More than 2.5 centimeter stones. Okay, so in gallbladder cancer, most common site is fundus. Fundus is the most common site. Now, I don't want you to remember the whole TNM classification. Just one thing you should remember, because the question which you'll get is that suppose you have done a cholecystectomy, and when the histopathology report comes, you have done the surgery for a simple gallstones. But when you get the histopathology report, maybe a week later, it will come to know that actually it is a cancer. So if the cancer is involving only the lamina propria, that is T1A, then the treatment is only cholecystectomy, a simple cholecystectomy. And in this scenario, the question which you get is that you have already done a cholecystectomy. So they ask, what is the further treatment you will do? You will not do anything, because the treatment you have already done. Okay, so the question, the answer for that will be no further treatment. But if it is anything beyond it, then you will do a radical cholecystectomy. Radical or extended cholecystectomy, in which you will call the patient again and remove a part of the liver, remove the lymph nodes in that area. So that is radical or extended cholecystectomy. One more thing in this classification which I want you to remember, because this question has recently been asked in the exam, the T2. T2 is when the tumor involves the perimuscular connective tissue. Okay, it has gone beyond the muscle, but it has not gone beyond the serosa. So you can say perimuscular or subserosal. Subserosal. What you should remember is T2A is when there is involvement on the peritoneal side, and T2B is when there is involvement on the hepatic side. Okay, so this thing I want you to focus. A is when it is involving the outer. Suppose this is the liver and this is the gallbladder. So if it is the fundus involvement towards the abdominal side, it is T2A. And if it is towards the liver side, it is T2B. Okay, so that is T2B. So just remember this thing in T2, what is A and B. Management we have seen, so choledocholithiasis. Choledocholithiasis, patient comes with pain, fever and jaundice. Investigation of choice, no confusion, MRCP. Okay, MRCP is the investigation of choice. ERCP is mainly done for the treatment. Remember, ERCP is for the treatment. MRCP is the investigation of choice. This is the ERCP showing a gallstone. This is the MRCP showing gallstones. This is a T-tube cholangiogram which shows a residual stone. Okay, so this is the T-tube cholangiogram showing a stone. Investigation of choice is MRCP. Cholangiocarcinoma. Cholangiocarcinoma, most common site is perihilar. Perihilar is the most common site. Cholangiocarcinoma can occur in the liver also, that is intrahepatic cholangiocarcinoma. It can occur in the distal CBD, but the most common is perihilar. There is a classification for this which is important, Bismuth-Corlett classification. When the cholangiocarcinoma involves only the common hepatic duct, it is Bismuth-Corlett 1. If it goes into the hilum, it is 2. If it is going in the right hepatic duct up to the secondary biliary radical, it is 3A. Left hepatic duct, 3B. And if it is going on bilateral secondary biliary radical, type 4. And surgery is possible in all of these except type 4. Type 4 is unresectable. Unresectable. Okay, so this is Bismuth-Corlett classification of cholangiocarcinoma. Okay, pancreas, see, although it is more of the anatomy, but there are two buds, dorsal pancreatic bud and the ventral pancreatic bud. Okay, so remember, the dorsal pancreatic bud does not move. It is a ventral pancreatic bud which moves 180 degree in the clockwise direction posteriorly, and it will fuse with the dorsal bud to form the normal pancreas. Okay, so what is the name of the dorsal pancreatic bud duct? Santorini. Okay, they have their duct, and ventral pancreatic bud, the duct is known as Wirsung duct. Okay, so suppose there is some abnormal rotation of this ventral pancreatic bud. So at that time, a ectopic part of the pancreas can be left in the second part of the duodenum. In the second part of the duodenum, that is known as annular pancreas. Okay, ectopic tissue around the second part of the duodenum, that is annular pancreas. Important thing which you are supposed to remember in this is that during the treatment, do not divide the ring. Don't divide the ring. If it is causing obstruction, what will you do? What is the treatment of choice? Duodenostomy. Okay. Anastomose the duodenum proximal to it, to the part distal to it. Okay, so you anastomose this part with this part, but don't try to divide the ring, because the ring will have some duct, and if you divide the ring, it will cause pancreatic fistula. On the X-ray, it will give a double bubble sign. Okay, double bubble sign, which you can also see in duodenal atresia. Double bubble sign. Pancreas divisum is a condition like we have seen when the ventral bud rotates and fuses with the dorsal bud. So in that case, if the both duct fail to fuse, Santorini becomes the main duct which is supplying or which is draining most of the pancreas, and Wirsung is just draining the inferior part of the head and uncinate process. So in this case, most of the times patients are fine, but if there is narrowing in this part, it can lead to acute pancreatitis because of the stasis. Acute pancreatitis. Okay, and in that case, the treatment is you do the ERCP and do the minor duodenal papillotomy. Just cut that area. Just cut this area. So that is minor duodenal papillotomy. Okay, so that is pancreas divisum. This is the management, minor duodenal papillotomy, if symptoms are there. Acute pancreatitis. What is the most common cause? Gallstones. Okay, gallstones are the most common cause, followed by alcohol. Okay, so talking about the severity, this is an important question. When will you say it is a severe acute pancreatitis? If there is a persistent organ failure for more than 48 hours. Persistent organ failure for more than 48 hours is the most acceptable definition for the severity of acute pancreatitis. The complications, there can be fluid collection. If that fluid collection around the pancreas is less than 4 weeks, it is acute pancreatic collection. And if it is for more than 4 weeks, it is pseudocyst. And if there is a solid collection, less than 4 weeks, acute necrotic collection, more than 4 weeks, walled-off necrosis. Walled-off necrosis. Okay, and remember, in all these complications, the indication for drainage is if these are infected. Okay, if it is sterile, then be it necrosis, be it collection, be it pseudocyst, you don't have to drain. Mostly it will resolve on its own. If these things are infected, then only you need to do some kind of drainage. Otherwise, drainage is not required. You manage the patient conservatively. Okay, so these are some of the signs which you can see in a hemorrhagic type of pancreatitis. Gray-Turner sign. Gray-Turner sign. What is this? Around the umbilicus. Cullen's sign. And in the inguinal region, Fox sign. Okay, so these are the signs of hemorrhagic pancreatitis. These are the signs of any retroperitoneal hemorrhage. You can see these signs. This you have already seen. Severe is persistent organ failure. Now, among the other criteria for severity, Ranson score, Glasgow bicep, I want you to remember this CRP. Okay, because this was asked recently, that if the C-reactive protein is more than 150, we consider it as severe acute pancreatitis. One criteria I want you to remember among all these, although all these criteria are used, Ranson's, Glasgow, bicep, Apache 2, modified CT severity index, but among all these, the most important is CRP. CRP more than 150, consider it as severe acute pancreatitis. For acute pancreatitis, investigation of choice is CECT. CECT will show you in the initial phase there will be edema and inflammation in the pancreas. This is the CECT showing a pseudocyst when there is well-defined wall pseudocyst. This is, as per me, a very, very important exam question. A plain X-ray and the complaints of patient is pain abdomen, especially after meals. In the same patient, if you do the CT scan, you will find something like this. What is your diagnosis? Okay, you can see calcification in this area. You can see calcification in the pancreas. Calcification in the pancreas, chronic pancreatitis. No confusion, chronic pancreatitis. The most common cause here is alcohol. Alcohol is the most common cause. And this is the classification used for chronic pancreatitis. Tigard-O classification. Toxic, idiopathic, genetic, autoimmune, recurrent, and obstructive type of reasons. So this is Tigard-O classification for chronic pancreatitis. Now, chronic pancreatitis is a irreversible damage. The pancreas will not going to become like the same before the disease. So the treatment is either you can manage the patient with the the painkillers and the pancreatic enzyme replacement. But at times you have to do the surgery when the pain is very severe. So these are the surgeries. Again, an important exam question. Tell me, what is this surgery? You will give a longitudinal incision in the pancreas, remove the stones and do a side-to-side pancreaticojejunostomy, or you can say longitudinal pancreaticojejunostomy. Name of surgery. Modified Pistos surgery. LPJ is modified Pistos surgery. What is this surgery? Where you will just cut the tail of the pancreas and do the end-to-end pancreaticojejunostomy. Duval surgery. So these two are the drainage procedures. Pistos and Duval are the drainage procedure. In the resectional procedure, what is this surgery? Where you will remove the head of the pancreas, sparing the duodenum. Duodenum preserving pancreatic head resection. Beger surgery. And if you do the pancreatic head coring, you can see the coring of the pancreatic head, and then you do the LPJ. That is a type of hybrid resectional and the drainage procedure, Fraze surgery. Okay, so these four surgeries, remember these two are the You can see the drainage procedures, and these two are the resectional procedures. In exam, you will get something like this image, and the only thing they will ask you is, what is this surgery? And this question has already been asked about the surgeries of chronic pancreatitis. What is this surgery? Past year's question. What is this surgery? You can see there is a tumor, and you will remove this part. You will remove the gallbladder, CBD, duodenum, head of the pancreas, and a part of jejunum. This is pancreatico-duodenectomy, commonly known as Whipple's surgery. Whipple's surgery. Another important question they ask is, after doing a Whipple surgery, what is the order of anastomosis, or what is the order of reconstruction? So first you will do the pancreatico-jejunostomy. Then you will do the hepatico-jejunostomy. And then you will do the gastro-jejunostomy. So pancreatico-jejunostomy, hepatico-jejunostomy, and then gastro-jejunostomy. Indications we have seen: carcinoma head of pancreas or periampullary cancer. Complications, the most common complication after doing a Whipple's is delayed gastric emptying. Delayed gastric emptying. And then there will be leak. Leak is the most dangerous. And if they ask among the three anastomosis, in which anastomosis the chances of leak is maximum, it is the pancreatico-jejunostomy. The chances of leak is more in the PJ or the pancreatico-jejunostomy. Periampullary cancer, just see these cancers, they come under periampullary. The treatment of all of this is Whipple's. But among these cancer, the duodenal carcinoma has best prognosis, and head of pancreas has worst prognosis. Okay, just this much about periampullary cancer. All these duodenal cancer, ampullary cancer, distal CBD, or carcinoma head of pancreas, they come under periampullary cancer. Cystic neoplasm of the pancreas. Okay, cystic neoplasm of the pancreas. So, in case of pseudocyst, this is not a neoplasm, this is cystic lesion. But if you see, in these cases, there will be increase in the amylase and CA will be low. In mucinous cystic neoplasm, increased CEA and amylase will be low. In serous cystic neoplasm, both amylase and CEA will be low. And in IPMN, both will be high. So this is one important difference between all these are the cystic lesions of the pancreas. One is an inflammatory cystic lesion. The other three are the malignant, or you can say the neoplastic cystic lesion. Okay, among this, one more thing about the serous cystic neoplasm, that it is benign, and the risk of malignancy is almost not there. You will see a cluster of grapes appearance on the imaging. Mucinous cystic neoplasm and IPMN. So you can remember like this, that if the cyst has a mucin, okay, mucinous or intraductal papillary mucinous neoplasm, all these three, they have risk of malignancy. So presence of mucin, there is risk of malignancy. No mucin, like in serous cystic, there is no malignancy. Okay, so in all these three cases, the malignancy risk is there. Most common, you can say here, neuroendocrine tumor of pancreas. Neuroendocrine tumor of pancreas, most common, non-functional. Non-functional. And if they ask most common functional neuroendocrine tumor, insulinoma. Most common functional associated with Men's syndrome, functional, is gastrinoma. Now, when you do the investigation, initial investigation is CT or MRI. If it is not localized, you can go for the nuclear scans like somatostatin receptor scintigraphy, also commonly known as octreoscan. Endoscopic ultrasound, you can say, is the best pre-op investigation for diagnosis, for localization. And overall, intra-op ultrasound is best for localization. So best investigation for localization is intraop ultrasound, but the best pre-op investigation for localization is endoscopic ultrasound. Okay, so these are the important things in the hepatobiliary system. Now we go to the urology part. Okay, so that was a quick revision in the hepatobiliary. Now we'll see the urology. What is this? Horseshoe kidney. Okay, this is horseshoe kidney. Investigation, although investigation of choice is CCT, but on IVP you will see what will you see on IVP? Flower vase appearance or the hand joining sign. At which level the ascent is stopped at the L3-L4 junction. At the L3-L4 junction, the kidney does not go up. So there is failure of ascent of the kidney and fusion of the poles. Complications, there can be stasis of urine, and because of stasis of urine, there can be recurrent UTIs and hydronephrosis, stone, all these things are seen. What is the important thing you will do in the treatment? If the patient is having symptoms, remember, do not divide the isthmus. Okay, don't divide the isthmus. This part should not be divided. Okay, you have to do a pyeloplasty because the ureters are angulated. So just do a pyeloplasty for the treatment. Do not divide the isthmus. What is this? This is duplication. Duplication of the ureter or duplication of the pelvis. Incidence is 1 in 150 live births. Okay, so you can say this is a very common congenital anomaly, although mostly the patients are asymptomatic. So one very important thing you should remember is, see, this is the lower pole ureter. This is the lower pole ureter, and this one is the upper pole ureter. So upper pole ureter will open distal and medial to the lower pole ureter. Distal and medial to the lower pole ureter. This is known as Weigert-Mayer's law or Weigert-Mayer's rule. Okay, Weigert-Mayer's law or Weigert-Mayer's rule, distal and medial. Upper pole is distal and medial. Complication, it can cause vesico-ureteric reflux, UTI. What is this diagnosis in this IVP? What can you see here? Ureterocele. Okay, so this is ureterocele. What is the name of sign on IVP? Adder head appearance or the cobra head appearance. Treatment is cystoscopic. You can do fulguration. What abnormality can you see in this IVP? On the right side, can you see on the right side, the proximal ureter is dilated. So this is seen in retrocaval ureter. Retrocaval ureter is a congenital anomaly of the IVC, which is causing compression of the right ureter, which will lead to proximal dilatation. The sign is known as reverse J sign. Reverse J sign. What is this? What can you see in this image? Yes, double ureter duplication is there, but what actually you are looking at in this image is the upper pole ureter. Many times it becomes ectopic. Okay, ectopic ureter. Instead of opening into the bladder, it is opening somewhere else. It is going more deep, more down. So mostly in this duplication, the upper pole ureter becomes ectopic because we know the upper pole ureter comes distally and medially, and many times it becomes ectopic. So this ectopic ureter, in the male, it opens in the prostatic urethra, or you can say the posterior urethra. But in females, it will open in the distal urethra, and it opens distal to the sphincter. So that's why in females there is incontinence of urine. Incontinence of urine, there will be continuous dribbling of the urine. In case of males, distal to the prostatic urethra is the sphincter, so you will not see incontinence. Instead, there will be recurrent UTI. There can be UTI, but incontinence will not be seen. Okay, so the treatment is you have to detach it from here and do the ureteric reimplantation, put the ureter back into the bladder. That is the treatment. Okay, this question was asked in 2 years back in the NEET ectopic ureter. This is polycystic kidney disease. What is the most common association? Okay, you will see cyst, the most commonly you can see in liver, you can see the cyst in the pancreas, you can see the cyst in the spleen. Apart from these cysts, what else you will see? Barryaneurysm. What in the cardiovascular system, what will you see? Mitral valve prolapse. In the colon, what will you see? Diverticula of colon. Okay, so polycystic kidney disease, sooner or later, this is going to cause a renal failure, and the definitive treatment is you have to do the transplantation. Okay, you need to do the transplantation in polycystic kidney disease. Identify the crystals which you will see in the urine. So patient is having renal stone. What are these crystals? Dumbbell shape. Where will you see? Calcium oxalate monohydrate. What kind of crystal you will see in dihydrate? Envelope shape. Okay, calcium oxalate dihydrate. Hexagonal stone, cystine stone. Coffin lid, triple phosphate coffin lid crystals. Okay, so these are the important shapes of urinary crystals in the urine. What is the investigation of choice for renal stone? Renal stone. Investigation of choice is NCCT-KUB, non-contrast CT of the kidney ureter bladder region. And if I ask you that if the patient is having pain, what is the drug of choice for renal stone pain or the renal colic? Renal colic. Okay, it is basically NSAIDs, most commonly used diclofenac. Diclofenac is the drug of choice. NCCT-KUB obviously we cannot do in the pregnant females. So in case of pregnant females, the investigation of choice is MRI. Okay, in pregnancy, MRI. Now, depending on the size of the stone, okay, less than 0.5 centimeter, there are chances it will spontaneously pass. Okay, we can say 5 mm. 5 mm is better. Okay, we'll write like this. Less than 5 mm spontaneous passage. ESWL is mainly preferred for less than 1 centimeter stone, 1 to 1.5. PCNL is preferred for more than 2 centimeter stone. Between 1 to 2 centimeter, either ESWL or retrograde intrarenal surgery, RIRS. Between 1 to 2 centimeter ESWL or RIRS. URS is for the ureteric stones. Ureteric stones. In case of pregnancy, which of these you can do? Among these 4 treatment options, what can you do in pregnancy? Okay, so both ESWL and PCNL are contraindicated in pregnancy. Both of these are contraindicated in pregnancy. So in pregnancy, you can do only these 2 things, URS or RIRS. See this IVP image. It is magnified to show you, I'll tell you if it is not clear, moth-eaten calyces. Diagnosis. What is this? On a plain X-ray, putty kidney or cement kidney. What is this? In the ureteric orifice, golf hole ureter. All these are findings of renal tuberculosis. If you send the urine, patient will come and patient will complain that I'm having pus in my urine. And if you send that pus for the culture sensitivity, you will find sterile, okay, sterile pyuria. Sterile pyuria. What is the treatment? Treatment is ATT. And ATT should be given for not just 6 months, you can say 6 to 9 months. Many people, they go for more than that, but you have to give for more than 6 months. 6 months ATT is not good enough for renal or for GI tuberculosis. Okay, this is a classification of renal cyst known as Bosniak classification. Bosniak classification, type 1, when the thin wall cyst and there is no septation, chances of malignancy you can say almost 0%. In type 2, you can see 1 or 2 thin septas, chances of malignancy again 0 to 2%. This is not 3, it is 2F. 2F. When there is increased number of thin septa and you can see a non-enhancing solid component also, chances of malignancy 5 to 10%. 3, when you will see honeycomb appearance, 50%. And type 4, when the cyst is irregular, there is enhancing solid component, the risk of malignancy is more than you can say 90%. Okay, so that's why in type 3 and 4, you will do surgery, do nephrectomy. Type 2, you will do follow-up. And type 1 and 2, no treatment. No treatment is required. You can tell the patient that these are not malignant and also it is not going to turn into cancer, so you can wait and watch in those cases. Okay, so this is Wozniak classification of renal cyst. Okay, this is a CT scan and the arrows are showing a tumor at the superior pole of the kidney. What is a tumor? Okay, you can see it is looking totally black. There is no solid component. Okay, so that's why it cannot be RCC. In RCC, you will see irregular shape. There can be some, hyperechoic thing, hyperdense thing. This is totally black. So this black thing is because of fat. So this is angiomyolipoma. Angiomyolipoma of the kidney. What is the syndrome which is associated? Tuberous sclerosis. This is the most common syndrome associated with angiomyolipoma. Importance is this, because it is made up of, you can see angio, blood vessel, muscle, fat. So because there are blood vessels present, it can lead to bleeding. And the chances of bleeding is much high in the females of the, the pregnant females. So that's why in that case it can lead to severe bleeding. Severe bleeding can occur in the females, pregnant females. That is known as, what do you call it as, that syndrome? Wunderlich syndrome. Wunderlich syndrome, severe bleeding in angiomyolipoma. Treatment. Asymptomatic patient, less than 4 centimeter. Follow-up. Symptomatic, more than 4 centimeter, or females of childbearing age. Females of childbearing age, you need to do the treatment. Treatment means either you can go for a partial nephrectomy, but these days the treatment of choice is angioembolization. Angioembolization. So asymptomatic less than 4 centimeter, you can follow up, but symptomatic more than 4 or females of childbearing age, partial nephrectomy or angioembolization. Next image is about the renal trauma. Although the trauma part will be done by the Sandeep sir in the next session, but in the renal trauma, AAST classification, grade 1 is when there is only subcapsular hematoma which is non-expanding. Grade 2 is there is cortical laceration less than 1 centimeter. Grade 3 is cortical laceration more than 1 centimeter, but it is not reaching to the collecting system. So it is not causing any urinary extravasation. Grade 4 is cortical laceration reaching up to the collecting system, or there is subsegmental vessel injury which is causing contained hematoma. And grade 5 is main artery or hilar avulsion. Grade 5, no doubt, you do the surgery, nephrectomy. Grade 1 to 3 in all these non-operative management, or you can say conservative management. Grade 4 is somewhere where there's some controversy. Okay, initial treatment is urinary stenting. Stenting. And if the stenting fails, if the patient is becoming hemodynamically unstable, then you will go for surgery. In this case also, nephrectomy. Okay, so you straight away don't go for nephrectomy in stage 4. Try to do the stenting. If you see, most of the time, the urinary leak will, it gets settled and spontaneously closed. Otherwise, if it is not treating the patient, if the patient is having continuous leak, if the patient is having expanding hematoma, if the patient is hemodynamically unstable, then you have to go for surgery. So this is a pathological cut section shown of a renal cell carcinoma. Okay, this is renal cell carcinoma. Most common type of renal cell carcinoma is clear cell. Which type of RCC occurs in the patient who are on hemodialysis? Papillary. So papillary you will see in patients of hemodialysis. Chromophobe is having best prognosis, and Bellini type is having worst prognosis. What are the syndromes associated with HCC? This is important question. With clear cell, you can see VHL syndrome, BAP1 mutant disease, and STH associated kidney cancer. Papillary, you will see hereditary leiomyoma and RCC syndrome, and hereditary papillary RCC syndrome. In these types, you can see other tumor types: Budd-Hogg-Dube syndrome, tuberous sclerosis, and Cowden syndrome. Okay, so the syndromes associated with RCC is an important question. Okay, there is a table given in the Bayesian love, so this is an important question. Syndromes associated with RCC: Budd-Hogg-Dube syndrome, tuberous sclerosis, Cowden syndrome. For the chromophobe Bellini, for papillary, hereditary leiomyoma and RCC, and hereditary papillary RCC. VHL, BAP1, and SDH associated with clear cell. Now the treatment is less than 4 centimeter tumor, bilateral RCC, VHL syndrome, and single functioning kidney. Single functioning kidney. If any of these things are there, you will go for a partial nephrectomy. Partial nephrectomy, or you can say nephron sparing surgery. Otherwise, you go for radical. Okay. In the other types, you will go for radical. So just remember the indication for partial nephrectomy: single functioning kidney, VHL, bilateral RCC, and less than 4 centimeters. This is a cystogram. The lower image is a cystogram showing what? Cystogram is when you put the dye in the bladder, and you can see that the dye is leaking into the peritoneal cavity. So this is a intraperitoneal rupture of bladder. Intraperitoneal rupture of bladder is not very common, but the question is, if you find this intraperitoneal rupture, what is the treatment? You always go for a exploratory laparotomy and repair of the bladder. You have to do surgery. Open the abdomen, do the peritoneal lavage because the urine is present in the peritoneal cavity, so that will cause peritonitis. Do the lavage and repair the bladder using the absorbable sutures. Remember, in the biliary system and in the urinary system, you will always use absorbable sutures. Okay, urinary system, biliary system, always absorbable. So you will use absorbable suture. Extraperitoneal rupture of bladder. Extraperitoneal rupture of bladder, the treatment is just put a Foley's catheter. You don't have to do any surgery. Just put a Foley's catheter. That injury will heal on its own. So in intraperitoneal, always surgery. In extraperitoneal, just Foley's catheter. Okay, so this is the next topic is, although a complicated topic, I'll just tell you very in an easy way. This is about neurogenic bladder. Neurogenic bladder. So in neurogenic bladder, remember, if the injury occurs in this part, okay, you can say the whole from the pons to the, you can say up to sacral spinal cord. Okay, this is suppose S2, S3, S4. So if the injury is above S2, S3, S4, you will see something which is known as upper motor neuron bladder. Upper motor neuron bladder in this injury. Upper motor neuron bladder mein, the problem is that the bladder will contract too frequently. Okay, patient has to go like every 10 minutes or 15 minutes, patient might have to go for the washroom, and every time he goes, little bit of urine will come. So in these cases, overactive bladder, detrusor sphincter dyssynergia. Means the detrusor will contract but sphincter will not relax. Increased frequency of micturition, and there can be urge incontinence. So in upper motor neuron bladder, the main treatment is anticholinergic drugs. If the injury occurs in the sacral spinal cord, this part, sacral spinal cord, then that is known as lower motor neuron bladder. Means the bladder will be flaccid. There will not be any contractions. Okay, the patient will not know when the bladder fills. The patient will not know that even if he wants to micturate, he cannot micturate because the bladder, the neural system is gone. So in these cases, the patient can have overflow incontinence. The main treatment option is, this was the question, treatment option is clean intermittent self-catheterization. Okay, clean intermittent self-catheterization. Patient has to go in like 3-4 hours to the washroom and he has to catheterize himself. Okay, otherwise the bladder there will be overflow incontinence. So remember, lower motor neuron bladder, it is a flaccid bladder. Upper motor neuron bladder is the, you can say, spastic bladder. Okay, and for the lower motor neuron, clean intermittent self-catheterization. Bladder carcinoma, transitional cell is the most common. Okay, aniline dyes or the benzene dyes, smoking are the main causes. Squamous cell carcinoma is mainly because of the vesicle stone, diverticula, or schistosomiasis. And adenocarcinoma is because of ectopia vesicae or patent urachus. Okay, now in this treatment part, you don't need to remember exactly the TNM staging. Just remember TA, that is non-invasive papillary tumor, TIS and T1. These are known as non-invasive tumor, non-invasive bladder tumor, and rest all are invasive. So in invasive tumor, first you will give neoadjuvant chemotherapy and then go for radical cystectomy. After radical cystectomy, you need to create a new bladder using the ideal loop. In non-invasive, You don't have to remove the bladder. You will go for transurethral resection of bladder tumor, TURBT. And after transurethral resection of the tumor, you need to go for intravesical chemotherapy or intravesical immunotherapy. What drug you give for immunotherapy? BCG. Okay, so BCG is given for intravesical immunotherapy. For chemotherapy, usually people they give mitomycin C. Mitomycin C. Okay, so non-invasive TURBT, invasive radical cystectomy. BCG is given for like at least 1 year and can be given up to 3 years. BPH. BPH, patient will present with the features of lower urinary tract symptoms. Okay, urgency, hesitancy, poor stream, lower urinary tract symptoms. Okay, something about PSA. Okay, raised PSA, what is the normal PSA value? Although it varies from age to age, but you can say less than 4 nanogram per ml is the normal. Although it varies from age to age. So this is the total. PSA velocity. If the PSA is increasing by more than 75 nanogram per ml per year, this is an indication for biopsy. This could be a cancer. Now free PSA. If you see in the PSA, there is free PSA and total PSA. If free PSA is more than 25%, then it is benign. And less than 18% is indication for biopsy. Okay, because in case of cancer, free PSA is less. It becomes complex. Free PSA is less in cancer. And PSA density is when you divide PSA divided by prostatic volume, more than 0.15 is indication for biopsy. Okay, so these are some of the important things about PSA, the total PSA, the free PSA, velocity, density. BPH management is mainly drugs, okay, alpha blocker or 5-alpha reductase inhibitor, tamsulosin, alfuzosin, 5-alpha reductase like finasteride, dutasteride. Indication for surgery. When will you do surgery in BPH? Okay. If there are severe symptoms which are not managed by the medical management. Okay, there is something known as International Prostate Symptom Score if it is more than 20. Acute retention, bilateral hydronephrosis, recurrent UTI, and recurrent hematuria. Okay, so these are some of the common indications where you will go for surgery. Otherwise, most of the times drugs are good enough to manage the patient's symptoms. From which lobe generally BPH arises? Median lobe. Median lobe, in the later part it can involve the lateral lobe also, but median lobe is the main from which it arises. Okay. Prostate cancer. Important things. Presentation, mostly the patients are asymptomatic. Generally, you diagnose prostate cancer on the screening. So what is the screening modality of choice for prostate cancer? PSA and digital rectal examination. What is the investigation of choice for prostate cancer? Very important. This year only this question was asked. TRUS-guided, transrectal ultrasound guided biopsy. This question was recently asked in one of the NEET exam. And what was given in that, this kind of image was shown, 4 of these images, and they asked what kind of biopsy you will do, how many biopsies. Okay, so although anatomically we say that prostate has like 5 lobes, 4 lobes, but clinically we say prostate is having two lobes, right and left. Clinically just two lobes. So how many biopsies you will take? 12 biopsies. This was the picture given in the option. Okay, 6 from each lobe. 6 from each lobe. Very important question. How many biopsies? 6 from each lobe. Most common site of metastasis, bone. Management. What is the most important thing if you get the question in your exam about the management? What will you see in the management part? What will you see if you get a question? You will see the age of the patient. Age. Okay, age less than 70 years. And so you have to go for, you can go for surgery, radical prostatectomy and other options. But if the age is more than 70 years, usually wait and watch. Okay, so instead of remembering the treatment stage wise, just remember if the age of patient is less than 70 years means the survival is more than 10 years. More than 10 years survival, you will do surgery, you will do radiation, or you can go for hormonal therapy and other things. But more than 70 years, you'll just wait and watch because prostate cancer is a very slow growing cancer. Okay, so if the diagnosis is made more than 70 years, it means the cancer is not going to kill the patient for next 10 to 15 years. Patient will die because of maybe something else, diabetes, hypertension, CAD. So in the screening guidelines also, these screening guidelines are up to 69 years only. Nobody does screening in more than 70-year-old patient. Okay, screening is also not done in more than 70 years because what will you gain after doing screening? Anyways, you are not going to treat the patient. Okay, so remember this thing, in the prostate cancer, the most important thing in the management part is the age of patient. This question, many people, many students, they ask me that how to identify the parts of urethra. What is this part? Penile. What is this part? Bulbar urethra. Okay, after penile and bulbar, in the membranous and prostatic urethra, you will not see that the dye is going very nicely, okay, because that is narrow. Okay, membranous urethra is narrow part, prostatic urethra, although it is dilatable. So this part, this much is membranous. And then there is prostatic. Okay, so penile and bulbar are considered as anterior urethra, membranous and prostatic are posterior urethra. In this case, you can see the dye is leaking from the membranous urethra. This is the prostatic part, this is the membranous, this is bulbar, this is penile. Okay, so this is membranous urethral injury. Membranous urethral injury. In the management, what you will not do. Very important. Patient comes to you with a history of pelvic trauma and the blood at the tip of the meatus. Patient complains of a distended bladder. Patient wants to micturate, but he could not. What will you not do? Do not put a Foley's catheter. So what will you do? SPC. Suprapubic catheterization. Then you will go for a retrograde urethrogram to see the injury, and then you will do a delayed repair. Delayed repair, you don't do the repair at that time. You can wait for like 8 weeks, and after that you can do the urethroplasty. Okay, delayed repair. Okay, abnormal opening on the ventral surface of the penis. Diagnosis? Hypospadias. It can be anterior, it can be mid, and it can be posterior. Anterior hypospadias is most common. Anterior, mid, and posterior hypospadias. What are the associated findings? What will you see in a patient of hypospadias apart from the abnormal opening on the ventral surface? Abnormal opening of the urethra on the ventral surface or the under surface of the penis. What else? Deviation of the penis towards the ventral side, that is ventral chordae. And you will see a hooded prepuce. Hooded prepuce. So, in the surgery, the timing of surgery should be between 6 to 12 months. The principle of surgery is important. The principle of surgery is first you will do the correction of the deformity. So first you will make the penis straight. That is orthoplasty. Then you will do the urethroplasty. And after that you will give the shape to the glans, that is granuloplasty. Okay, so this is the order: orthoplasty, urethroplasty, and then granuloplasty. In urethroplasty, you will create the urethra by using what? From where you will take the tissue from the patient's body or the child's body to create the urethra. You can take from the buccal mucosa or you can take from the prepuce. So because prepuce is going to be used for the correction, that's why in these cases, circumcision is contraindicated. Okay, you will not do circumcision because that prepuce can be used for the urethroplasty. Okay, in the next condition, there is persistent painful erection of the penis for more than 4 hours. Painful erection for more than 4 hours. What is the condition? Priapism. What are the two types of priapism? Arterial and venous. Which is more dangerous? Arterial is high flow, it is less dangerous. Venous is low flow and it is more dangerous. Okay, venous is dangerous because it can lead to, in the corpora cavernosa, it can lead to fibrosis and permanent damage, which can later cause erectile dysfunctions. So in arterial type of priapism, it is not very dangerous. You can go for angioembolization. The investigation you can do by doing a penile Doppler. In the venous type, initially you will do aspiration of the blood. Then you can give injection phenylephrine. Then you can do the different shunt surgeries. Shunt surgeries, you can create the shunt between the corpora cavernosa and the corpora spongiosa, between the corpora cavernosa and the saphenous vein, between the corpora cavernosa and the dorsal vein of penis. So shunt surgery, you will give some way for that venous blood to go back into the circulation, otherwise it will lead to permanent damage in the corpora cavernosa. This image is important, also known as eggplant deformity. What is this? Fracture penis or penile fracture. Cause is mostly occurs at the time of during sexual intercourse. There is injury to tunica albuginea. Tunica albuginea is the covering of corpora cavernosa, and management is always surgery. You have to do the repair. Okay, although the surgery will take like hardly 15 minutes, but if you don't do surgery, this is not going to get better. So surgery is always done in penile fracture. This is torsion of testis. Torsion of testis. Complication, if you don't do the surgery within 6 hours, it can lead to gangrene of that side testis. Risk factor, inversion of testis. Okay, bell clapper deformity, when there is, you can say the tunica vaginalis is inserting higher up into the cord. And if there is increased gap between the epididymis and the testis. Between epididymis and testis. Usually the age group in which you will see this is like 10 to 25 years. Management is urgent surgery. You don't wait for the Doppler or some investigation, go for surgery. If the testis is healthy, then do the detorsion. If the testis is gangrenous, do the resection. And in both the cases, what is very important, what else you will do? Orchidopexy of the contralateral side. Okay, you have to fix the contralateral side also in these cases, in this detorsion and orchidopexy. If gangrenous resection, and in both the cases, you have to fix the other side because whatever thing was caused this torsion, that can occur on the other side also. Okay, this is testicular cancer. Types are seminoma and non-seminomatous germ cell tumor. What is the investigation? Investigation of choice and the treatment or the surgery same, that is high inguinal orchidectomy. Okay, don't do any kind of FNAC or biopsy via the scrotum, because the scrotum has a different lymphatic drainage. Testis, the lymphatic drainage goes to the retroperitoneal lymph nodes. So that's why high inguinal orchidectomy is the investigation also, and you can say the surgery also. Management depends on the staging, but the main thing you should remember is in case of seminoma and non-seminomatous germ cell tumor, orchidectomy you have already done. Stage 1. You can do observation or you can go for radiotherapy. Non-seminomatous, observation, or go for retroperitoneal lymph node dissection. Okay, retroperitoneal lymph node dissection means you will surgically remove those lymph nodes which are present around the aorta or the IVC. Seminoma is a radiosensitive, so you can manage with radiotherapy. Stage 2A and 2B, radiotherapy, or you can say chemotherapy, although, okay, let's make it simple. Just remember radiotherapy. In this stage 2A and 2B, retroperitoneal lymph node dissection. Okay, now stage 1 is when the tumor is limited to testis, no lymph node involvement, that is stage 1. 2A is when there is lymph node less than 2 centimeter. 2B is lymph node 2 to 5 centimeter. 2C is lymph node more than 5 centimeter. And 3 is when there is distant metastasis. You will go for chemotherapy. In this also, chemotherapy. Okay, so the main difference is what you are doing in this case. Because seminoma is radiosensitive, so you are doing radiotherapy. Non-seminomatous, you are removing the lymph nodes surgically. In 2C and 3, in both the cases, chemotherapy is given by bleomycin, etoposide, and platin, 3 cycles of this BEP, bleomycin, etoposide, and cisplatin. Last image and the last slide. Okay, so what is the diagnosis? Okay, although it does not become that extensive, in this picture I have shown a kind of more extensive type of Fournier's gangrene. Fournier's gangrene. So what is the causative organism? Usually a mixed aerobic and anaerobic infection cause this Fournier's gangrene. It can be caused by Clostridium, it can be caused by Streptococcus pyogenes. Important thing is that the testis is spared. Testis is spared. Rice water, you can say discharge, you can see in these cases, mostly seen in immunocompromised elderly patients, diabetic patient. And the management is you need to do the debridement and IV antibiotics. Okay, so early diagnosis, early management is the key in the treatment of these cases. Otherwise, in the literature, the mortality rate associated with Fournier's gangrene is more than 25%. Okay, so thank you very much. And this was the, you can say a quick revision of the urology and the hepatobiliary system. I hope, I know most of you, you know these things. Okay, so the important thing, for your preparation is that discipline is one of the most important things. Okay, so you have to be disciplined in your studies. Like suppose you say that you want to study for 8 hours in a day, 8 hours is more than enough, but make sure whatever happens, marriage or football match or whatever, you have to study 8 hours. Okay, so there are like almost significant time is left, so you can revise your things, and I wish you all the best for your exams. Okay, so thank you.